Hello, my name is Dr. Marc Singer. It's my privilege to speak with you today and share my presentation, Optimizing Surgical Recovery with Nutrition Therapy. Please review my disclosure. This presentation is supported by Nestle Health Science. Again, my name is Marc Singer. I'm a colon and rectal surgeon speaking to you today from the United States. I'm a board-certified general surgeon and colon and rectal surgeon. I completed my colon and rectal surgical training at Washington University in St. Louis, and I currently practice at Loyola University Medical Center here in Chicago, Illinois. So that you know where I'm speaking to you from, here you see a map of the United States. Highlighted in red is the state of Illinois, and in Illinois it is the city of Chicago. Loyola University has its medical campus just on the outskirts of Chicago. Here you see our hospital, medical school, nursing school, and research facilities. Again, my presentation is Optimizing Surgical Recovery with Nutrition Therapy. Background for this presentation is that surgical complications in the United States and around the world are a significant problem. Here you see some statistics highlighting the need for quality improvement efforts. Close to half of hospital costs are related to surgery. And specific to colon and rectal surgery, you see nearly 1 in 4 patients are readmitted to the hospital within the first 90 days postoperatively. At least $1.6 billion US are direct costs related to surgical site infections from this population. And the average cost related to surgical site infection is in excess of $20,000. Surgical site infection accounts for nearly 1/3 of all hospital-acquired infections. So there's significant motivation to reduce morbidity and cost of care by reducing surgical site infections. Efforts to reduce infection typically focus on one of two problems: either host-specific factors, such as the medical morbidities of the surgical patient, or the environment, including bacterial contamination of surgical wounds, microbiome of the colon, contamination of instruments, etc. But one of the missing pieces is nutrition therapy, because in many ways, nutrition represents a bridge between the host and the environment. To start out, I think it's important to review the timeline of surgical nutrition interventions and review the variety of opportunities to intervene, because these are often confused. Here you see a general timeline in the preoperative and postoperative states. On the top, you see highlighted in blue, immunonutrition, and this would be the primary focus of our discussion today. This occurs in the immediate perioperative period, that is 5 days before and after surgery. On the bottom, you see highlighted in pink, oral nutrition supplements. And this is standard dietary therapy or conventional oral nutrition supplements. And this process takes a much longer period of time in the range of 2 to 4 weeks before and after surgery. And although we won't discuss it in detail today, carbohydrate loading is practiced in the immediate preoperative period on the night before and the morning of surgery. We will make brief mention of this later in the presentation. So let's start by trying to define what is immunonutrition. It's critical to understand that immunonutrition is different than standard oral nutritional supplements. It is designed to meet specific nutritional requirements for the surgical patient, and benefits can be realized regardless of the overall nutritional status of the patient. It contains key substrates, and the product we will be discussing today contains arginine, omega-3 fatty acids, and nucleotides. Some products contain other ingredients such as glutamine or antioxidants, which we will not discuss. Again, I would like to highlight the differences between standard nutrition and immunonutrition. Standard nutrition supplements focus on protein and calories, and this addresses malnutrition by improving the overall nutritional status. This requires significant time, typically 2 to 4 weeks. However, immunonutrition derives benefit not from just protein and calories, but from the specific ingredients that modulate the immune, vascular, and inflammatory responses in the surgical patient. These requirements are unique to patients undergoing surgical stress. And the timeline, again, is much shorter, 5 days pre-op or post-op. What made me personally realize the importance and the opportunity that existed regarding immunonutrition was my review of these two clinical trials. Nearly 20 years ago, Dr. Braga out of Italy published his experience with 150 malnourished patients undergoing elective cancer operations. And here you see a highlight of the data from this trial. By giving patients standard nutrition, they experienced a high rate of complications in excess of 40%. Patients who were supplemented with preoperative immunonutrition in green had a nice reduction in complications. In patients who received periop, that is before and after surgery, immunonutrition had an even greater benefit with reduction of complications. Now, this is impressive, but many physicians interpreted this data such that patients who were malnourished received a supplement and they did better. And that seemed obvious to most. However, a follow-up publication was what really changed my perspective on this whole strategy of optimization. Here you see the publication in which Dr. Braga from Italy selected 200 well-nourished patients. These were patients who were of normal nutritional status undergoing an elective operation. And what you see is that compared to patients undergoing standard nutritional therapy, those receiving pre-op or peri-op immunonutrition had a dramatic reduction in infectious complications. And this made me realize that we could improve the results on patients who were well-nourished, patients who show up to the office with a cancer or other surgical problem, who are otherwise well-nourished and reasonably good surgical candidates. And we could do better on their postoperative outcomes. And this seemed like a tremendous opportunity for our patients. It's important, again, to distinguish between immunonutrition and general nutrition and understand the misconceptions. This schematic shows complications as related to nutritional status. And this is obvious to all of us who take care of surgical patients. Poorly nourished patients on the left have a high rate of complications. Well, one of the misperceptions is that all you need is more protein and calories. Again, this is standard nutritional supplementation. Yes, this will drive the curve to the right and put patients on the well-nourished end of the graph. However, immunonutrition does maintain a benefit even for these patients on the well-nourished side, because immunonutrition pushes the entire curve downwards. So you see, even if patients are on the right side of the curve in the well-nourished category, immunonutrition drives the entire curve down. As mentioned previously, immunonutrition contains arginine, omega-3 fatty acids, and nucleotides. So let's discuss how these can affect the wound healing process and recovery after surgery. We won't spend too much time on the basic science, but it's important to understand the mechanisms of action as to why these help our patients. The first ingredient, arginine, really plays three roles. You see those roles outlined here. First, it improves wound healing by way of the arginase 1 pathway. Arginine contributes to collagen production, which is critical for tissue repair and wound healing. Second, in the center, arginine supports T-cell function, which supports the immune system to reduce postoperative infection. And third, by way of the nitric oxide synthase pathway, it brings additional vasodilation and oxygen to the healing wound, which improves perfusion, critical for a healing wound. What's important to remember is that surgery represents a state of relative arginine deficiency. Even in a well-nourished patient, the increased demands in the postoperative period put patients in this status of relative arginine deficiency. And because they do not have adequate arginine, they experience T-cell dysfunction leading to infection and decreased nitric oxide leading to wound complications. It is possible, though, to preload cells with arginine, and this has been nicely demonstrated in a very elegant laboratory experiment in which cells were preloaded with arginine, which showed that T cells had improved function for at least 7 to 10 days afterwards. And this is really the cellular explanation as to why we can give our patients arginine before surgery and expect a sustained response after surgery. But arginine, again, is just one of the key ingredients. It's not the entirety of the story. Second are omega-3 fatty acids derived from fish oil. Omega-3 fatty acids are known to minimize the inflammatory response by decreasing inflammatory mediators and increase the immune response by enhancing lymphocyte function. In addition, there's an interaction with arginine to further improve the mechanisms described on the last slide. And finally, nucleotides. Nucleotides, we know, are the building blocks for DNA and RNA, which are essential for rapidly replicating cells, such as bone marrow and intestinal cells. So for GI surgery, critical to heal wounds. Now let's talk about some of the evidence for this particular blend of arginine, omega-3 fatty acids, and nucleotides. This is really the best studied combination in a variety of immunonutrition products. There's more than 40 randomized trials, multiple meta-analyses. And this product has been studied in a variety of surgical patients, most commonly in GI cancer patients, but as you see in this list, many other kinds of patients, even those without cancer. A high-level review of the data is seen here. This is a meta-analysis published by Drover more than 10 years ago, in which he analyzed 35 randomized trials with over 3,400 patients. Most of these were in patients undergoing elective GI cancer surgery. And in this, the various studies looked at pre-op, peri-op, or post-op use of arginine supplemented immunonutrition. And as you see on the bottom, the primary outcome was reduction in infection by more than 40% and reduction in length of stay in the hospital by better than 2 days. And this was for the single intervention of immunonutrition. Let's also take a brief look at a few important subset analyses. In that same meta-analysis, the authors broke down the patients by GI surgery or non-GI surgery, and both groups sustained benefit and reduction of infections. Patients undergoing upper GI surgery or lower GI surgery both benefited. And in the center, you see patients treated with impact, that is, supplements with arginine, omega-3 fatty acids, and nucleotides, had the clear benefit. But those treated with other formulas that did not include those three critical ingredients did not sustain a benefit in reduction of infections. And finally, they established that patients treated pre-op or peri-op or even just post-op all enjoyed the benefit, although those treated peri-op, that is before and after surgery, had the greatest benefit. More recently, we can review a similar meta-analysis which was updated with additional data. This was published by Yu and colleagues from Harbin Medical University in Harbin, China. This meta-analysis contained now 61 randomized trials with nearly 6,000 patients, again, mostly undergoing GI cancer surgery. And in this, they found that immunonutrition was associated with reduction in infection and specifically wound infection. And here you see the graphical display. Wound infection was reduced by 28% with the single intervention. Anastomotic leak in those patients undergoing GI cancer surgery was reduced by 30%. I would highlight that with all of the improvement in perioperative care, stapling technology, minimally invasive surgery, it's hard to find any other intervention that would reduce anastomotic leak by as great as 30% with a single intervention. And again, they showed a reduction in length of stay in the hospital by better than 2 days. And similarly, they did subset analyses of different products, and they found that only those patients treated with arginine, omega-3 fatty acids, and nucleotides enjoyed this benefit, but those treated with other combinations did not. So how can this product be implemented in the real world? Well, hospitals look to a variety of different programs to improve on their results. Sometimes they're looking to improve surgical site infections. Sometimes they're looking to reduce length of stay. Sometimes to reduce cost. In the United States, most of these efforts have really been combined into the larger effort of enhanced recovery, often called enhanced recovery after surgery, or ERAS. And this really implements a clinical protocol aimed at serving all of these improvement efforts. One of the early programs in the United States was developed in the state of Washington, and it was called Strong for Surgery. And this really started with a relatively small protocol focusing on 4 simple parameters: optimizing nutrition, including preoperative immunonutrition supplementation, smoking cessation, optimizing medication management, and tight blood sugar control. This was so successful, it was adopted by the American College of Surgeons and made available to its members throughout the entire country. What they found was in these patients treated by this simple pathway, not only did patients enjoy reduction in surgical site infection and other complications, but the early fear of discharging patients from the hospital in short order would be met with frequent readmissions. And you can see in this graph, it was not. Patients treated with immunonutrition and the remainder of the bundle, in fact, had a much lower readmission rate, both at 30 days, 90 days, and sustained out to 100 days. And this is because reduction in complications leads to fewer readmissions. Similarly, with fewer complications and readmissions, there was a significant reduction in cost. You can see here that in the initial hospital stay, cost was reduced by better than $2,000. And when patients were tracked for 180 days, reduction in cost grew to over $5,000. So fears of spending too much money on the optimization program should be alleviated by the fact that reduction in complications more than offsets the costs. And here you see a graph looking at one of the previously presented meta-analyses that further explains the reduction in cost. This analysis breaks down the cost savings based on the complication rate. All groups of surgical patients are going to have some rate of complication. And what you see here is that at really any complication rate, there's going to be a cost reduction because the reduction in complications will always lead to saving money. And even if you're fortunate enough to have excellent results with a complication rate of 5% or even 3%, there's always room to save a little bit with infection reduction and save money. So the point of this is really that at any rate of complication, immunonutrition will pay for itself by reducing complications. So what did we do here in my own practice at Loyola University? Well, at the start of our effort, we aimed to reduce 2 primary outcome measures: surgical site infection and length of stay. But we knew we had challenges that we had to overcome, mainly with access to dietitians and access to the immunonutrition products themselves. So let me just describe what our experience was like. In the United States, many nutrition professionals who are called registered dietitians or RDs are employed by hospitals. However, American insurance companies and government-funded healthcare does not pay for the routine evaluation of patients by registered dietitians. And so every patient that we see that we're evaluating for the operating room cannot see a dietitian because there's no funding for these individuals. In addition, in the United States, insurance companies and government-funded healthcare do not pay for oral nutrition products, including oral immunonutrition, for preoperative optimization. So whether you're using standard nutrition like you see here or immunonutrition, as you see in the bottom corner, the expense of these products either falls to the patients or to somebody else. Now, many of our patients cannot afford to pay for these products, but also patients that do have appropriate money to pay for these products sometimes have an expectation that their insurance will pay for it. They feel that if these are important to their care, their insurance company would, of course, provide it. But the truth is, again, in the United States, no insurance companies pay for oral nutrition products. And so that leaves the hospital to cover the cost. And I'm sure all of your hospitals, like mine, are reluctant to take on additional cost in the care of surgical patients. However, when reviewing the data that I presented to you already with our cost, with our hospital administrators, it became clear that this is not just an expense, but really an investment by the hospital in the care of these patients. And they came to see that it reduces the overall cost of care. And so for that reason, our hospital chose to purchase the immunonutrition product and distribute it to our surgical patients at no cost to them. So how did we build our solutions? First, we engaged our dietitians in a discussion of our enhanced recovery protocol as we decided what our protocol would look like in our hospital. We value their input and recognize that they're a critical part of the care of surgical patients. But because they're not available to every surgical patient, we decided that the initial assessment of patients would be made by the surgeon. And we really just use a simple history and ask patients how they've been eating, if they have difficulty eating and swelling, if they subjectively feel they've been losing weight. Next, we assess their BMI or body mass index. And last, we check albumin on all of our surgical patients. And as a general guideline, we use 3 grams per deciliter as a safe minimum level to take patients to the operating room. And if we feel patients are at risk or seem to be malnourished, then we selectively consult the dietitians to evaluate and intervene. So what does that look like? When a patient first comes to see their surgeon and I assess that they are of normal nutritional status, I treat them with immunonutrition for 5 days preoperatively and then proceed to the operating room. Again, remember that immunonutrition benefits even patients who are of normal nutritional status. However, if my initial assessment shows patients to be malnourished, we then refer them on to the dietitian. And once that happens, it opens up a full array of nutritional interventions available to them. It may be simple dietary counseling to eat a healthy diet. It may include standard nutritional supplements or immunonutrition. In the extreme cases, it may include enteral supplementation by way of nasogastric or other feeding access. And in the most severe cases, total parenteral nutrition or TPN for those few patients who need it. So we have really focused routine patient optimization around immunonutrition. I can't emphasize enough that we're relying on the fact that immunonutrition will benefit well-nourished patients undergoing routine elective surgery. And so this is applicable to all of our patients. It does not require extensive evaluation in terms of special scans or complicated lab testing. And this does not require the routine utilization of registered dietitians. And so we can reserve those resources for only the most malnourished patients. And as demonstrated, this is cost-effective for the hospital because their small investment in the care of patients yields great returns by reduction of complications post-operatively. And we've incorporated this into our enhanced recovery program, which you see here. I'm not going to review this in great detail, but I will point out that we do have a comprehensive enhanced recovery protocol spanning the entire spectrum of care of surgical patients. And it does include a variety of nutritional interventions. As mentioned, the nutritional assessment by surgeon or dietitian preoperatively. We do make use of carbohydrate loading immediately before surgery, immunonutrition for 5 days preoperatively, and then we continue immunonutrition while the patients are in the hospital postoperatively. Our preoperative phase of our protocol focuses on type diabetes management, again, immunonutrition, bowel prep, including mechanical and antibiotic prep, and skin decontamination. Because we are asking patients to do a variety of things, we provide to them patient education materials, immunonutrition, the carbohydrate drink, and the skin decontamination, and we package this up and give this to our patients at no cost. This was really a revolution in the way in which we care for our patients because most hospitals in the United States do not distribute these types of products to their patients at no cost. But again, we recognize that this was an investment in their care, and so we provide it to them so as to benefit both patients and the hospital alike. Immediately before surgery, we focus on, again, skin decontamination, patient warming, blood sugar management, and non-opioid pain control. In the operating room, we really focus on minimally invasive surgery in my own practice with an emphasis on robotic surgery and a variety of efforts such as wound protectors and triclosan impregnated sutures to reduce infection. And post-operatively, careful wound management and early feeding, including other techniques such as chewing gum to stimulate bowel function. Enhanced recovery is well accepted around the world. There's no need to review the data extensively. Here you see just one meta-analysis. And really all all enhanced recovery protocols show similar results. Reduction in morbidity approximately 40% and length of stay reduced by about 2 days with no increase in readmissions. Our experience at Loyola has been similar. After instituting this protocol, including the immunonutrition as discussed, our length of stay immediately began to fall, and this has been sustained over time. Similarly, our surgical site infection rate immediately began to fall, and again has been sustained over time. And so this has been a real success story for us. So in summary, the immunonutrition blend of arginine, fatty acids, and nucleotides has been shown to be efficacious and effective to improve outcomes following major elective surgery. All three immunonutrients that we have discussed have a mechanistic role in the support of immune function and have been studied as part of enhanced recovery protocols. And finally, improved surgical quality and lower hospital costs are associated with the use of immunonutrition. Thank you for your attention. I appreciate this. And again, I appreciate the opportunity to share my experience with you regarding the optimization of surgical patients.